Hey everyone, we are in Unit 11 and we've done it. This is our last unit. We will be talking about death, dying, and grief. Not the best topic, but it is our last one. We'll talk about this in class, so I'm not going to go too much into it now, but what is a good death? And a lot of it and why this kind of topic is here is hospice versus palliative care. So what is hospice? Hospice really started in the 1960s. We had a lot more people going to the hospital to die. Um, and it's a model that very much supports and cares for patients experiencing death. So our doctor will have to certify that the patient has a terminal illness with 6 months or less to live, if the disease runs its normal course. Now, we know some of these common diagnoses, dementia, COPD, cancer, heart disease, liver, Parkinson's. It's really hard to kind of say, hey, this is, definitely 6 months or less. We're not necessarily going to kick the patient out. We're just going to continue to recertify. It is available for everyone, regardless of their ability to pay. Um, it is very much a Medicare type program for those who have the ability to have it. It is a multidisciplinary approach. So we are looking at the entire patient, their family, religion, right, psychosocial, culture, all of that stuff. In hospice, the focus is on care, not cure. So in hospice, the patient can still get medications, they can still have some treatments, but we're not doing things to prolong life. And the care also extends to that patient's family because they are there with them, talking and kind of communicating with everyone. We do have a few settings, freestanding home, nursing home, hospital, so our patients could be in a variety of areas and having hospice care. Palliative care is a little different. Palliative care is an umbrella term, and hospice is under palliative care. Palliative care could be anyone with a chronic illness, diabetes, heart disease, dementia, and it's basically comfort care. We're still treating, I'm still trying to help you, I'm still trying to prolong life, but it's patient and family centered. I want you to be able to make decisions and choices on your own and decrease kind of your suffering. So when we look at the kind of some of the similarities between hospice and palliative care, right, that family and patient, not just patient, but we're including the family in it too. We want our patients to make their own choices. We tend to talk about the golden rule, treat others as you want to be treated. But if you've never heard of it, I would encourage you to look up the platinum rule because especially when we kind of talk about end of life care, treat others as they want to be treated. What does that patient want? Their autonomy, their ability to make decisions. And the family and the patient should direct all the care that is happening. Um, I'm hitting buttons today, y'all. Okay, so when we talk about our death and dying theories, Kubler-Ross is one y'all should be familiar with. Now these stages, and I know I kind of put a picture that's straight kind of line, but it's not linear. These could be a tangled web. At any point in time, a patient, experiencing a loss could enter, or patient experiencing grief could enter at any point. You could start with depression, then go to denial, then bargaining, then anger, then acceptance, then anger. Basically just depends on what's happening. Denial, I don't have a problem. We're shocked. We're asking for second and third opinions. You know that can't be right. Run the test again. Anger, we're starting to come to terms, but we're unhappy. When we talk about the anger, it could be at other people around them. We'll talk about a movie where there was someone and their loved one was sick and going in for chemo, and he got super angry and he's just yelling and screaming at the nurses. He wasn't angry at the nurses. He was angry at that situation. We need to, one, we always want to try to, again, anticipate and, prevent anger from occurring, but respect our patient and respect the family and their attention and time. So bargaining with a higher power. If I can live to see my kids' graduation, I will do X, Y, and Z. If I can just make it a few more months until this happens, we start trying to make deals with whoever it is we believe in. Depression, um, we can't avoid that loss anymore, right? We are feeling that depression, um, guilt, shame, sadness, right? We have to let that patient, let the family feel that sadness and be sad. Acceptance is not happiness, and I know it has a smiley face. However, it's peacefulness. I remember my grandfather passed away. He was making his own plans for the funeral. He was on hospice. We kind of knew it was coming. And he was like, pallbearers, told my grandmother she had to wear a bikini. It didn't mean he was happy with the fact that he was dying. However, he accepted the fact that this is what was happening for him. So we have a few different ways of facilitating death. Artificial nutrition and hydration. We're going to start there. Feeding tubes, IV fluid, not needed at end of life and can potentially make our patient worse. When we have a patient who is nearing death, they don't need the food, they don't need the calories, right? They might not be able to eat. But eating is, and we talked about this with eating disorders, is such a vital part of life that the family, when they're looking at their loved one not eating, they might be asking you, like, well, what can we do? How do we get this patient to eat more? And we just have to let the family know, like, hey, look, it's okay. Um, if we do give feeding tubes or IV fluids, we run the risk of serious side effects that can make it worse. Now, again, if we have a patient who wants to eat, absolutely feed them, but we cannot force feed a patient. So when it comes to facilitating death, we have three types of euthanasia. So voluntary euthanasia is physician-assisted suicide, sometimes also known as medical aid in dying, a few different terms. This is going to be mandated by each state, at least here in America. Each country, when we talk about countries, Canada has certain rules, being one of the ones closer. Where in Canada, right, it is legal. In America, it is done by the state. So this is someone who has a terminal illness. They go to a few different doctors. The doctors all basically say, like, yep, hey, this is it. This is what's happening. And then we provide this patient with medications that they can kind of take, or we can give them to help expedite that death. Um, there are different stances on voluntary euthanasia from a few different organizations, and we'll talk a little bit about it. Your textbook definitely takes a anti-voluntary, anti-medical aid and dying standpoint, but we do have pros and cons for each side. So passive euthanasia is withholding medication, some type of sustaining life. So if we're talking about passive euthanasia, if we have someone in life support and they want to end life support, that would be a passive euthanasia. Involuntary euthanasia is actively ending a person's life without their consent. And that one kind of, I know we kind of jumped to like murder. That's a hard one when we talk about involuntary euthanasia. I had a student a few quarters ago who brought up a show. It's on Apple TV. I put in a little clip about it, 5 Days at Memorial. So 5 Days at Memorial looks at Memorial Hospital in New Orleans after Hurricane Katrina. And some of the healthcare providers were left with some decisions. We have no food, we have no electricity, we have no water, we have no way out of here. What do we do for some of these patients? It is very iffy. And in the legalities, I think the healthcare providers kind of got off without any charges, and the main one is actually still practicing. But it definitely does when you look at, how would you make this decision? It puts it in a new and different perspective. So when we talk about that medical aid in dying, different organizations have different statements. We reference the book Health Providers, different associations. It's in your textbook in box 30.2, but we have a few, right? Individual liberty, for and against, right? Patient has a right to make their own decisions. However, the government has a power to protect citizens. Autonomy. Patients, and especially competent patients, have the right to make their own decisions. If we have a patient who is not competent, they cannot make that decision. Your book also talks about human beings are the stewards, but not the absolute, masters of the gift of life. So is it always our decision as a human? Quality of care. That's a hard one. If we, stopped banning, if we made, let's put it this way, if we made medical aid in dying, more readily available, would other providers want to give as high quality end of life care? Non-maleficence and beneficence kind of go hand in hand, right? Do no harm, do good. As healthcare providers, we take a right to not harm our patients, but if we do medical aid in dying, are we promoting and protecting that patient's life? And kind of the same thing for beneficence. How do we do good for our patients if we are causing their death? Um, both sides, again, super tricky. This is a little clip we'll watch it in class from How to Die in Oregon. Oregon was one of the first states in America that legalized medical aid in dying. So at end of life, things we have to consider: communication. Communication can be hard. What do you say? And honestly, that presence, just being there, listening, talking about it. If the patient isn't talking, just sitting by the bedside, having those open-ended questions, right? Using silence if silence is needed. And then we also want to take care of that symptom management. Um, and that symptom management is that key component of palliative care, right? Pain management, constipation, um, shortness of breath, delirium are things we want to address. Pain management is one of the big ones. And I don't know about y'all, but we don't want our loved ones at the end of their life in pain. So if we have someone and it is the end of the life, we're not concerned about addiction, right? We're not concerned about addiction on hospice. There is something called the rule of double effect. And what that means is physicians, advanced practice nurses are able to make decisions regarding pain management without concern for the fact that pain management might cause a patient to die sooner. However, we have little evidence that shows that pain management causes people to die earlier. Pain management causes patients just not to die in pain. But there will always be that kind of point in time where it's like, hey, I just gave this patient their pain meds, and 2 hours later, they passed away. Was it because of the pain meds? Statistically, it is not because of the pain meds. By giving them the pain meds, we just let them die in peace. Anticipatory grief, we're mourning a future loss. So we find out that our loved one has Alzheimer's. And we know, hey, eventually, slow progressive process. We find out a loved one has cancer. And we start grieving from the moment we find out. Sustenance, again, we've talked about that. If the patient can swallow, eat, we provide food and water. If not, we need to be cautious. We do have some developmental tasks in dying. I've put some of them kind of on the screen, but just, tying up loose ends, letting things go, reaching out to loved ones we haven't been talking about, saying goodbye, acceptance of the finality, surrendering, just, do we have a will? Who is getting what information? It could be a lot of different things. Um, we have a specific slide talking about palliative care for those with dementia. It's a little bit hard because we have the communication difficulties, we have the memory difficulties, and we really just want to take a proactive approach. We want to try to anticipate the needs and focus on that person rather than the disease process. We want to stay on top of pain. We don't want to be chasing that pain. We want to look at our medications that they're on and be like, hey, is it causing more side effects? Because that's one of the problems. We start putting you on medications and then those meds start causing side effects. Then we're giving you more meds to deal with the side effects. We just want to do what we can to be proactive to manage and help keep this patient calm and support the family members. More developmental tasks in dying. Actually, we already did that. Somehow these have double slides. So when we talk about the dying process, so this is specifically what we might see at that extreme end of life, right? Decrease in appetite, drowsy, tired, increase in heart rate, but a decrease in blood pressure, that modeling of the skin, the urine output, changes in breathing, agitation. When we have a patient who passes, we want to listen to that heartbeat for 2 minutes to be able to pronounce that time of death. Depending on where we are, it will vary on who can pronounce time of death. I always laugh about that. Families remember the actions of the nurse. About 2 years ago, I was at a baby shower. Yeah, actually probably a year ago because the kid just had her first birthday. I was at a baby shower for a friend, and someone asked, what do you do? And I mentioned I was a nurse. Y'all, in the middle of this baby shower, this random stranger started talking to me about her mother passing away, and how amazing the hospice nurses were and everything that everyone did for her. And her mother had passed away quite a bit. It was an older individual who was telling me this. Her mother had passed away quite a bit before this. And here we are in this middle of baby shower, and she's talking to me about like death. So we just have to remember respect for the family, respect for the loved one. Culture and family will kind of vary in how we do things. We want to invite the family to participate. and we want to make sure that we are doing what they want us to do. There's certain customs and cultures, customs in each culture, in each religion that has to occur. After death, we have grieving, and it's a normal response to loss, right? Grieving is a major, death is a life crisis. It affects us in every area. Bereavement is a time period. Bereavement is a time period after death. Mourning are the things we are doing. Do you have a celebration of life? Do you have a viewing? Do you have a funeral? Well, grieving are kind of those thoughts, feelings, and emotion. So grief, thoughts, feelings, and emotions. Bereavement, period of time. Mourning, things we are doing. I would take a look in your textbook at page 561, table 30.3, and we'll look at in class on the difference between grief versus major depression. We have very similar symptoms in each, but how they are portrayed are different. So in grief, we're going to look at guilt. I'm guilty that I did not spend more time with a loved one. In major depressive disorder, we're guilty about everything. So in grief, we are thinking about death, but we're thinking about, dying to be with that loved one again. In major depression, we're just thinking about death in general. Persistent complex bereavement disorder is bereavement that is lasting, again, time frame, beyond 12 months or 6 months in kids. Complicated grieving is distress that follows. It's grief, and again, grieving, there is no normative, but this is something that is, 7, 10, 12 years later, the person is still grieving. They're constantly thinking about dying. They're thinking about the loved one. They're not going to work. They're not eating. They're not drinking. They're not taking care of themselves. So in complicated grieving, the patient is not functionally able to process. They might be blaming themselves for what happened. It is a much larger processing condition. So when we talk about communication grief, this is one of my favorite slides all quarter, what to say and what not to say. My favorite, have you thought about getting a new husband, wife, dog? Right, we want to stay away from the cliches. A lot of these questions, right, we're in a process of elimination it as we go through to try to find what is the best. This must be difficult for you. I can only imagine, right? We cannot talk. We do not say anything about our experiences. I know it was hard for me when my mother passed away. We don't know what this patient's relationship was like with their mother. And honestly, that's super good point. What if they hated their mother? And now they have all of these mixed emotions. Maybe their mother was extremely abusive to them growing up. And now they have this kind of love, hate, all these crazy emotions that they don't know how to deal with. So we very much have to stick with our appropriate statements. So when we talk about self-care for nurses, compassion fatigue is a thing, especially if we're working in an area where we're constantly surrounded by our patients passing away. We might have a patient who we are very attached to, and it can be hard for us because, right, our patient dies and we just got to move on to the next patient. We have to remember this is happening to the patient and not to us. However, that countertransference, we have issues we need to talk about. So we have to make sure that after we have, a patient, a special patient, multiple patients pass away, that we have someone to talk to. We need to have a healthy, balanced life, right? Those boundaries. When our boss is like, hey, can you pick up this extra shift? Our answer is no. Make sure we're taking that time off to take care of us. That wraps up. That's it, y'all. We're done. If you have any questions, please let me know.